Good morning to all. Today's topic is on furcation involvement and its management. Coming to learning outcomes, apply the classification of furcation involvement in a given situation. Identify the etiological factors that can favor furcation involvement. Identification of the furcation involvement and the application of probing techniques. Express your views on furcation defense a formidable problem. Prepare a treatment plan for various grades of furcation involvement in a given situation. Identify the factors that can affect the treatment plan. Identify the problems of a given situation. Interpret them and propose treatment solutions. Coming to the introduction part, loss of alveolar bone leading to exposure of the furcation region of a posterior tooth has always been a perplexing situation for the dental practitioner. Furcation areas present some of the greatest challenges to the success of periodontal therapy. Bower described furcation as an area of complex anatomic morphology. Coming to the definition, what do you mean by furcation involvement? The term furcation involvement refers to the invasion of the bifurcation and trifurcation of multi-rooted teeth by periodontal disease. You can see that this is the area that is the furcation area of a molar of a maxillary molar. You can see that mesial furcation is there, distal furcation is there, and the buccal furcation is there. So these are the two buccal roots and this is the palatal root. So this is the area, it is called as the furcation. So if the periodontitis, if it is affecting the trifurcation of the multi-rooted tooth, then it is called as furcation involvement. Furcation defect. It is defined as any soft tissue or hard tissue loss seen at the area of furcation. So how it is getting progressed? As you know, there will be inflammatory process when there is a foreign body or bacterial accumulation. So the progress of this inflammatory periodontal disease, if it is not getting treated at that point, it will get progressed and it will lead to attachment loss. And with increased attachment loss, it can reach up to the furcation and the that is a bifurcation or trifurcation area of the multi-rooted teeth. So coming to the important part, that is etiological factors. So the primary etiological factor in the development of furcation defect is bacterial plaque and the inflammatory consequences that result from its long-term presence, and the extent of attachment loss required to produce a furcation defect is quite variable, and it can be related to local anatomic factors, local developmental anomalies. So under local anatomic factors, this can be of different types. This can influence the prognosis and treatment. It can be widely separated roots. Roots are separated but can be close, fused to roots separated only in their apical portion, and presence of enamel projections. So there is this local anatomic factors and local developmental anomalies can influence the primary etiological factor. Also, there can be influence of iatrogenic factors that can lead to furcation involvement. Endodontic origin can lead to furcation involvement. Age can increase. The age itself cannot cause furcation involvement, but they can increase the chances of getting furcation involvement, and then trauma from occlusion. So coming to the details of each, first one, there is the bacterial plaque. So always the extension of inflammatory changes. So first it starts with gingivitis and then it periodontitis. If the attachment loss is getting increased and if it is progressing to furcation area, so there is loss of attachment and bone loss in the furcation area. So ultimately furcation involvement. Then trauma from occlusion. So always these furcation areas are more sensitive compared to the areas. So they are more susceptible to excessive occlusal forces. So this can lead to periodontal breakdown and it can lead to furcation involvement. Then comes to the endodontic origin. Endodontic origin, you can see that pulpal pathosis in a multi-rooted teeth. This can lead to, if there is any opening to the furcation area, it can cause furcal invasion. There is accessory pulpal canals in the furcation area may extend this pulpal inflammation to the furcation. So in that way, it can lead to furcation involvement. And then coming to the iatrogenic origin, That is the faulty dentistry like perforating during root canal treatment and poorly contoured restoration. So this can lead to attachment loss in the furcation area, that is furcation involvement. Age, the prevalence and the extent of attachment loss can get increased with age, as you know, due to this supraeruption and with the recession caused due to age. This can lead to furcation involvement. So the severity of the furcation problems increases with age. So coming to the details of local anatomic factors. So initially we told that this can influence the primary etiological factor. So before coming to the details of the role of local anatomic factors in the etiology, prognosis, and treatment plan, we will just describe the anatomy of the tooth. That is, you can see that this is the area. This is the tooth, that is the furcation entrance area. So that is a transitional area between divided and undivided part of the root. So this is the furcation entrance, and you can see these are the two parts of the two roots. It is being divided into two roots. There is a divided region of the root complex. Okay, and this is the fornix, that is a roof of the furcation. Okay, furcation entrance, root cone, divided portion, and then fornix. Okay, and then coming to the root trunk. Root trunk, this is the area, that is the undivided region of the root complex, that is root trunk, and this is the root length. Root length, that is the root cone. This can be like root cone, that is the cone shaped two roots. The length is this thing. So this is the root length. Okay, so when we tell about root trunk, so we have to tell that the height of the root trunk it matters, because you can say that if there is shorter root trunk, if it is shorter root trunk, the involvement there are more chances to get the furcation involvement easily. That is, lesser clinical attachment is needed to get the furcation involvement. So once a furcation is exposed, so this, but the treatment plan, okay, risk is more, but the prognosis will be more. That is, once a furcation is exposed, it is easily accessible to maintenance procedures. Okay, since it is short root trunk, so this can be easily be reached by the root planing instruments, and also it facilitates the surgical procedures, and you can maintain the crown root ratio also if there is short root trunk. Okay, but in the case of teeth with unusually long root trunks, you can see that if the root trunk is very long, okay, it may not be appropriate candidate for the treatment once the furcation has been affected. So that is, risk is very less. But if it is affected, that means there is half of the portion will get involved. And also the treatment also, the accessibility is very less, and the maintenance will be very less, and also surgical procedures also, it's very difficult to attain. So that is the root trunk. So when you compare a root length, as you know that it is directly related to the quantity of attachment. Okay, increased root length means increased attachment. Okay, so the teeth with long root trunks and short roots, that is, if the long root trunks and short roots, that means if it is once it is involved, the furcation involvement is there, then the prognosis will be very poor, because the short root length and the rest of the attachment will be very less. So, but with the teeth with long roots and short to moderate root trunk, that means, okay, if once it is involved, if it is involved with the furcation involvement, then the long root helps to maintain the attachment. So that is what more good prognosis will be with long roots with short to moderate root length. So coming to root form, okay, so there can be different types of root forms. This also will play an important role. So it can be like curved roots. Usually you can see that in case of mandibular molar, it will be in the mesial roots, and also sometimes this can happen in the other roots also. This is the case of a premolar. You can see that this curvature and fluting that leads to root perforation easily while doing the endodontic therapy, and also it can complicate the post placement also during restoration. and also this can have increased incidence of vertical root fracture. So there is root forms also will play an important role. Okay, and also there is, if the furcation involvement is there, and the prognosis will be depending on root forms also. Then coming to the interradicular dimension, as we said before, that is a degree of separation of roots. So in the diagram we have seen that separate like different types of anatomical factors. This can be fused and this cannot be fused, and this can be wider space, it can be too close. So closely approximated or fused roots will have less prognosis because the accessibility will be very less, and the maintenance will be very less. Whereas teeth with widely separated, the treatment is very easy and the maintenance is very easy. Okay, so coming to the anatomy of furcation. Okay, this can also lead to increased incidence of furcation involvement. For example, bifurcation ridges, concavity in the dome, and possible accessory canals complicates not only the treatment but also periodontal maintenance. So these all will complicate the maintenance. So coming to cemento enamel projections, you can see that there is the local factor. These are the local factors, enamel, pearls and all. So that favors the onset of periodontal lesions. So this can affect plaque removal and can complicate the scaling and root planing, and it should be removed to facilitate the maintenance. So this Maskers and Hoskins 1964 has classified into three types of cemento enamel projections, that is grade 1, that is extend from cemento-enamel junction of the tooth towards the furcation entrance. But this grade 2 is approaches the entrance, so it will just will extend. Grade 1 is just extending, and other one is approaching the entrance. Third one, it is extending horizontally into the furcation. So they have classified it into three grades. Coming to diagnosis and furcation defects, careful probing is required to determine the presence and extent of furcation involvement, the position of the attachment related to the furcation, and the extent and configuration of the furcation defect. So, out of this, the most important one is the neighbor's probe to determine the furcation areas. So, you can see this. This is the neighbor's probe. This is a curved probe. It can be used to get access to this furcation areas. Markings, it's from 3 to 12 out of the 3 to 6 colored codings and 9 to 12 colored codings. And this probing, these factors always determine, that is include the factors which determine the probing. There is always a morphology of the affected tooth, the position of the tooth related to the adjacent tooth, and the local anatomy of the bone, configuration of any bony defects, presence and extent of the dental diseases. And this next coming the transgingival sounding, that is also very important. If you cannot access the with the neighbor's probe, you have to go for the transgingival sounding. That is the extended probing to reach till the bone level. So this is usually the procedure will be carried out using LA, and is used to confirm the extent and configuration of the furcation defect or the infrabony compound. So coming to the proximal approach and palatal approach of neighbor's probe, you can see that this is the palatal approach, and this is the proximal approach. Coming to other diagnostic aids, so they can be radiographs to identify the furcation, and also CVCT can be used, and also periendoscopic visualization of furcation. Coming to the classification, so we are dealing with three different classification. Out of that, the most important one is Glickman classification in 1953, which is based on localized configuration of the bony deformity. So what is grade 1? So we have 4 grades under Glickman. The first one is grade 1. So grade 1 is incipient or early lesion, so which will be usually suprabony pocket, and slight bone loss will be there. Slight catch will be there with the explorer. So usually we won't see any radiographic changes. So that is the grade 1 furcation involvement, incipient lesion. Second, coming to grade 2, so little more extension. So it is called as cul-de-sac type. Why? Because the one side will be open up and the other side will be closed. And this also, the extension will be different. This can be slight entrance of the periodontal probe. This is that allows partial penetration of the probe, and usually you can see vertical bone loss. And this radiography features may or may not depict involvement. Okay, that is this the second grade 2. Coming to grade 3, you can see the differences in the radiograph and the clinical area. That is, bone is not attached to the dome of the furcation, and the opening may be filled with soft tissue or may not be visible. So that is what which allows the through and through movement of the probe, and also this cannot be visible. This is usually covered by soft tissue. So sometimes this probing may interfere with the bifurcation ridges or facialingual bony margin. So this can happen sometimes. So this display always defect as a display it as a radiolucent area in the crotch of the tooth. So that is grade 3 furcation defect. And then coming to the grade 4, you can see that the interdental bone is completely destroyed. So it allows the through and through passage of the periodontal probe, and the soft tissues will get receded by this time. So the furcation can be easily be visible. So usually a tunnel exists between the roots of such an affected tooth. That is grade 4. Coming to the next classification, there is Ham, Naiman, and Lind in 1975 has proposed the furcation classification based on horizontal component. So how much it is getting entered into the furcation area horizontally. So what is class 1? Class 1, there is a furcation defect if it is entering less than 3 mm. Then it is class 1. If it is entering that is more than 3 mm, but it is not through and through, then it is grade 2. So furcation defect, if it is going through and through, then it is class 3. Coming to the next classification based on vertical component given by Tarnow and Fletcher in 1984. So subclass A, subclass B, and subclass C. So here it has been taken based on this furcation vertical component. For example, furcation involvement with vertical bone loss of 1 to 3 mm. Subclass A, furcation involvement vertical bone loss 4 to 6 mm. Subclass B, and if it is furcation involvement that is more than 7 mm, that is subclass C. So there is the vertical component. So coming to clinical features of furcation involvement, you can always expect the clinical features same as that of periodontitis. That is redness, swelling, increased bleeding tendency, pain, and suppuration. So coming to the important part of furcation, that is treatment. So what treatment object is? Facilitate maintenance. So it always the first one is the facilitate. It has to facilitate maintenance. It has to prevent further attachment loss, and also we have to obliterate the furcation defects. So the selection of the therapeutic mode will always vary with the class of furcation involvement and the extent and configuration of bone loss, and also depending on the anatomical factors. Coming to treatment strategies, we have different procedures under different categories. There is maintenance of existing furcation, increasing access to furcation, and elimination of furcation. So under maintenance of furcation, there is scaling and root planing, adjunct to scaling and root planing. Then that is chlorhexidine, tetracycline fibers can be done, and you can cleanse the area with all these techniques. And coming to the increased access to furcation, you can go for all the surgical procedures like gingivectomy, apically positioned flap, or modified Bidman flap. So these flaps we will be studying later. And then odontoplasty, osteoplasty, ostectomy. There is odontoplasty shaping the tooth surface, osteoplasty shaping the bone, ostectomy, that is removal of bone. So all these are termed as furcation plasty. So this was used before frequently for getting access to furcation, but this would allow easier furcation, hygiene into the furcation area. So these techniques have limited usefulness today. But in the compromised individual whose teeth cannot be extracted or in whom conservative therapy has failed, these surgical techniques can be used for getting increased oral hygiene maintenance. So always this patient awareness of oral hygiene maintenance. So coming to the treatment of various grades. So first one, there is a grade 1 early defects, that is incipient or early furcation defects. These are amenable to conservative periodontal therapy. So since it is suprabony and has not entered the furcation, you can always go with the like oral hygiene maintenance and scaling and root planing. And also if there is no access, you can go for the surgical procedures to get access to it. So mainly oral hygiene maintenance is more important. So this can be attained by non-surgical therapy, scaling and root planing, along with buccal tech delivery or mouthwashes and all. So for getting this scaling and root planing, you can use slim tips, ultrasonic tips are available, and some of the curates that get easily access to furcation area. For example, you can note down some of the examples for furcation curates. There is DeMarco curates, diamond files, keratin furcation curates, and mini figracy curates. Okay, so this with the instruments you can lead to resolution of inflammation and the repair of periodontal ligament and bone, and it can lead to restoration of periodontal health. So, and also this odontoplasty, osteoplasty, or osteotomy, there is a furcation plasty will also help. There is if there is any overhanging margins of restoration, facial groove, or anything like cement, like enamel projections. So this can be eliminated by odontoplasty, recontouring, or replacement to facilitate the oral hygiene maintenance. So we have some of the instruments for that is periotor instruments are there, like to remove this and to remove overhanging fillings and enamel projections. And also always access, we should be careful while removing. There is access to the removal for this odontoplasty, it can lead to sensitivity and caries. So coming to grade 2 furcation, as you know, once a horizontal component to the furcation has developed, so therapy becomes more complicated anyway compared to grade 1. So when we tell about shallow horizontal involvement without significant vertical bone loss, usually responds favorably to localized flap procedures with odontoplasty and osteoplasty. So horizontal involvement, you can go with the oral hygiene maintenance and the accessibility to the furcation. Okay, and then isolated deep class 2 furcation may respond well to flap procedures with osteoplasty and odontoplasty, but this reduces the term of the furcation and alters gingival contours to facilitate the patient's plaque removal. So in you can see that when there is involvement of there is grade 2, there is usually it goes with the flap procedures. So here you can see that this has been exposed, the bone has been exposed. You can see that the furcation involvement, a slight grade 2 furcation involvement. So this is a thick bony plate around this, that is making it more complicated for the oral hygiene maintenance. So it has been removed, that is shape osteoplasty has been done, and we have made like this. See, the contouring of bone has been done. There is osteoplasty and osteotomy. So just here only there is osseous surgery has been done, not a regenerative procedure. It's just the resective procedure, and then the flap has been placed back with the sutures. So this is the healing. So when it is advanced from grade 2 to grade 4, if there is any advanced stage, there is a development of a significant horizontal component to one or more furcations of a multi-rooted tooth, or a development of a D vertical component to the furcation poses additional problems. So non-surgical treatment is usually ineffective in this case because the ability to instrument the tooth surface adequately is compromised. For this, if it is advanced case, definitely you have to go for periodontal surgery, and if it is reaching there is complicating with the pulpal involvement, and then you have to go with the endodontic therapy to completely seal the access to the pulpal areas, and also restoration of the tooth may be required to retain the tooth. So coming to the surgical therapy, there is what are the indications for surgical approach? A significant horizontal component of one or more furcations of a multi-rooted teeth. If there is inability to adequately instrument the furcation area by routine scaling and root planing, and if there is persistent inflammation or exudate after adequate phase 1 therapy and good oral hygiene, so always there is an indication for surgical approach. So coming to surgical or open debridement, when you tell that, so when there is the open method. So if there is greater calculus removal can be done with than closed open debridement. Always we are getting more access to the area by opening the flap. Okay, so this is the furcation area and this will be opened. So ultrasonic scaling can be done, and so this can lead to narrow furcations and dermofurcation. So surgical access and increased operator experience significantly enhance calculus removal in molar furcation. So always this ultrasonic will restrict the area to narrow furcations and according to dome of the furcation. So surgical access will be more. So if sufficient subgingival access is not possible with a closed approach for furcated molars with deep lesions, then open scaling using flap procedure is more effective. So with the furcation area, as you know, this will, if there is a narrow opening, you cannot like allow this instrument to get in, so we can go for the open method along with the scaling. So vertical deformities respond favorably to a variety of surgical procedures. So if there is a vertical deformity, always you can go for the bone grafts with or without membranes. So that is what the procedure. Surgical procedures can be of different types. We can do gingivectomy, that or apically positioned flap or modified Widman flap. So you can just note down this because we will be taking in details in your coming lectures. So that is gingivectomy. It's just the eliminating the tissue. If there is the tissue, it is covering the furcation area or it is inhibiting the oral hygiene maintenance, you can go for the gingival removal. Okay, that is gingivectomy. And that is by reducing or eliminating the soft tissue pockets of the furcation area. The same way, apically positioned flap also, it is removing the tissue. The minimal amount of tissue will be removed. Okay, and there is a vertical incision will be given, and this will be exposed, and then this will get clean the area, and or if there is any osteoplasty osteotomy need to be done, can be done, and then it will be placed little apically and then sutured. So the area will be uncovered, so that increases the access for plaque control. Okay, and this decreases the pocket depth also. And also there is an additional benefit is that for apically positioned flap, it is the amount of attached gingiva will be increased in this case. So this is a modified Windman flap, same like that. The other thing, the pocket lining will be removed. Okay, so if it is covering in soft tissue, pocket lining will be removed. You can erase the flap and then do the all the osteoplasty osteectomy and make it favorable for oral hygiene maintenance, and then it can be sutured back to the original position. Okay, so that is modified Widman flap. So you can see that this is the procedure done. We are giving the flap reflection, and then we are making all the bone plateaus, everything, osteoplasty, everything done. And this is more like horizontal, so we cannot go for regenerative procedure. So then cleaning up and then keeping the flap back. That is more like a apically positioned flap. And this area is uncovered and it facilitates oral hygiene maintenance. You can see that the firm gingival tissue here. So then coming to the guided tissue regeneration. So once there is regenerative procedure, if it has to be done, then it has to go with the guided tissue regeneration. So there is a predictable outcome of GTR therapy was demonstrated only in degree 2 furcation wall mandibular molars. So this is more, there is this type of crater type of bone loss, so degree 2 furcation involvement. Always this facilitate the bone graft placement, and over that you can keep the membrane like this, and this is the end result. You can see this facilitates the bone formation. So this less favorable results in other types of furcation defects, and it is could be considered in areas with isolated degree 2 furcation. Coming to bone grafts and the membrane, you can see that, so this can be used along with bone grafts with or without membrane. So this is the case, they have been it has been used with bone grafts and the barrier membrane. So you can see that here The bone graft has been placed in this. So from starting from this is the preoperative view. This is the preoperative IOPA probing depth, increased probing depth. Then incision has been done and then reflected, and then you can see the bony defect here, and then this facilitates the regenerative procedure. Since it is a crater type, you can place the bone grafts here. So this is lead to bone graft placement. Okay, then the membrane has been placed over it and then sutured back and then the pack placed. And then this is the post-operative view at 6 months, and this is the IOPA. So you can see that the increase in bone level compared to pre-operative, and this is the post-operative. So that is additional placement of membrane over bone graft always promotes perial fibroblast and osteoblast cell adhesion, which enhances periodontal regeneration through collagen membrane hemostatic and chemostatic function. So this is the procedure done with the GTR membrane. You can see that this is the bone defect and this GTR membrane has been placed, and then this being closed, and then this is the post-operative. So next, coming to the root separation and root resection. So that comes in the category of eliminating the furcation. So what is root separation? What is root resection? Root separation, this can be called as hemisection if the one part is removed, and if it is bicuspidation, if it is equally dividing into two parts. So root separation can be of different types, which involves the sectioning of the root complex and maintenance of all roots. So you can see that this is the diagram, that is a direction of if this is more involved, this can be removed. So that is root resection. If it is the interdental part is involved, then you can do it bicuspidization. This is the dividing it into equal parts. And if the one root alone is involved, then this can be removed. That is the hemisection. So this is the root resection if one root is getting removed without the removal of crown part. So that is the root resection. So coming to the decision making of root resection, that is depending on various factors like which has the least amount of bony support, which will obliterate the furcation, which facilitate plaque removal by the patient, and also the most difficult for the dentodontist or restorative dentist to treat, and the ability of the remaining roots of the tooth after resection to serve as an abutment if a fixed or removable partial denture is planned. So you can see that in this diagram, so this is the crater formed, and this is a more involvement of distobuccal root, and this has been decided for the removal. This is with the oblique cut given, and this has been removed, and this is the then the crown has been placed. So always this will be done, that is after root canal treatment. So after debridement, the recession of the root begins with the exposure of the furcation on the root to be removed. So the removal of a small amount of facial or palatal bone is definitely needed to provide access to this furcation area. Okay, and a cut is then directed with just apical to the contact point. So usually this cut is being made with the high speed surgical length fissure or cross cut fissure cut by bird. So coming to the factors to be considered, the length of the root trunk, the divergence between the root cones and the length and the shape of the root cones, fusion between the root cones, amount of remaining support around individual roots, stability of individual roots, access for oral hygiene devices. So all these factors are very important before going for the root resection procedure, whether this can be indicated or not. So for these factors to be considered. So coming to the important part, that is indications and contraindications of root resection or root separation. So you can go through it. There is severe bone loss affecting one or more roots, untreatable with regenerative procedures. Class 2 or class 3 furcation invasions. So this is just the descriptive what we told before. Endodontic or conservative indications are there. Okay, then prosthetic indications are there. There is severe root proximity inadequate for a proper embrasure space, or root trunk fracture or decay with invasion of the biological bit. So these are all the indications for root resection. And coming to the contraindications, there is this general contraindications to periodontal surgery. So any systemic factors or poor oral hygiene, and if there is fused roots and unfavorable tissue architecture or endodontic factors, that is, we cannot be treated endodontically, then it cannot go for root resection, or excessive deepening of pulp chamber. So increased destruction of uh, tooth, crown portion, and respiratory factors. There is internal root decay is present, presence of a cemented post, and strategic consideration. Consider adjacent teeth available for conventional prosthetic restoration. Consider removable processes, and if it is considered for implants. So these are some of the indications and contraindications. So coming to the procedure, that is the bicuspidization or hemisection. So as we told, hemisection is the splitting of two rooted tooth into two separate portions. So this can be called as bicuspidization. Hemisection will be like this one root can be removed. So one area, one tooth can be removed, and that is the hemisection. Whereas bicuspidization will be separated. Crown and root portion will be separated together. So the main advantage is that to enhance plaque control, to convert the part of the tooth more susceptible to caries, that is attack into metal, and the indications are grade 3 furcation involvement. If it is through and through, this can be done. This bicuspidization or hemisection can be done, and disadvantage is that time, expense, and attention to detail required for successful completion. So if they cannot withstand that is two different tooth, then that is there is no there is prognosis will be poor. So advanced bone loss in the proximal area, if there is advanced bone loss, this can lead to that is failure of the procedure. So you can see that this is through and through procedures, this sorry through and through furcation involvement, and this has been made by hemisection. There is separation of the root has been placed, and then it has been divided, and one root has been removed. With the crown portion it has been removed. So there is the hemisection. So coming to tunnel preparation, this is always with a deep grade 2 and grade 3, just to make a tunnel area, to make it accessible to maintenance. Surgical exposure and management of the entire furcation area of the affected molar. Short root trunk, if it is short root trunk, so that increase risk of furcation involvement. And if there is a wide separation angle and long divergence between the mesial and distal root, always it is a good case for tunneling. And disadvantage is that this can lead to root sensitivity and carious lesions on the denuded root surfaces. You can see that this area, so this will make a little more accessible with the bone removal, and so this is the procedure, and this allows the oral hygiene maintenance. So this is the picture showing the tunneling, and this facility is the maintenance. Coming to obliteration of furcation, there is ways eliminate the anatomic knife. So if it is grade 2 and all, this can be like treated if it is exposed with this. So this can lead to, there is, it can obliterate the furcation defect by polymeric reinforced zinc oxide eugenol, that is the intermediate restorative material. So this is physiologically acceptable to gingival tissues, that is to prevent caries and simplified plaque control. So this is the more advantages over GIC, that is the limitations are protection from moisture and blood contamination necessary for the first 24 hours, and finishing of the restoration should also be done after 24 hours. So use of light cure GIC, this facilitates rapid initial setting and polymerization. So this is the procedure. You can see that this is the furcation involvement of grade 2. and this leads to the flap exposure and coming to the restoration and then keeping the flap back and suturing, and the copac has been given. So this is a general like summary of all the treatments for all the procedures. You can go through it. So furcation defects always a prognosis is depends on various factors. So you can see that this will vary according to the anatomic factors, that is mandibular or buccal maxillary, that is class 2 furcation always will have good prognosis, most predictable prognosis. Mesial or distal maxillary class 2 furcations in the medium way, least predictable is the class 3 furcations. Conclusion: thorough knowledge of the anatomy of the furcation is essential for successful treatment. Nature and extent of involvement alters the treatment plan. To conclude, a rich knowledge on time diagnosis and appropriate treatment plan helps in reducing the risk of attachment loss due to furcation involvement. So, thank you. Have a nice day.